So in this panel, I'm Elizabeth Donahue. I know many of you. I run public and external affairs here at the school, so it's quite an honor to moderate this panel. Before we get started, I just wanted to give a little bit of a shout out to Jeff Brown. Where's Jeff? Yeah, who did a huge amount of work on organizing today. So anyway, it was really a good collaborative effort and a nice example of how our school likes to reach out and work with other organizations, particularly in our state. So it was a nice collaboration. Thank you. So I think we're going to do something similar to what the last panel did, because I like to copy Heather in everything. And start with a little bit of, rather than going through your full bio, which, as she said, you have them in your packets, but to tell us what you're working on in terms of gun violence right now in your current work, but also what motivated you to do that work. So, Joel?
Sure. So my name is Joel Fine. I work as a physician in the emergency department at the Children's Hospital of Philadelphia, and I'm honored to be here today with our panelists and the panelists before. I came to this work probably very similarly to the way that Bill Schwab came to it, which is working in, and many of you may have done it the same way, working in an inner city in an emergency department and feeling quite helpless at the amount of violence and violent injury that we saw. Kind of motivated me and many others to work to prevent that violence. It was as simple as that. And so I was born in Brooklyn. No, I'm just kidding. So the work that I go back to kind of in the early 2000s was really around hospital-based violence prevention, looking at the kids that we saw in the emergency departments at both HUP and CHOP, and HUP being the next door to CHOP, 50 feet, not 50 miles, and taking kind of a holistic approach to preventing the next violent injury. So we kind of gave them what we would call wraparound services, a transitional counselor, advocate, mentor, similar to some of the other programs that are existing in the country. And that worked for about 6 years until our funding dried up. And we, as a legacy for that, pretty much were left with two things. One is a relationship with Big Brother, Big Sister in southeastern PA, where we could theoretically and more easily get kids bigs if they needed to. And more importantly, every person who comes in violently injured to our Children's Hospital Emergency Department gets a social work consult and an evaluation. So we kind of left a legacy of that. Thinking more broadly, my work has then expanded to community-based violence prevention, and I'm lucky enough to have many of my colleagues here, including Steve Leff and others, who work in schools and communities to do primary violence prevention. And we ran a violence prevention center funded by the CDC for about 5 or 6 years. That got me into the public health world, and I've been a zealot in this ever since. So,
Charlie?
My name's Charlie Ransford. I work for an organization called Cure Violence. We used to go by the name Ceasefire, which might be more known to some of you. There was a movie not too long ago called The Interrupters about our program. And so what Cure Violence does is, we label ourselves as a public health approach to violence prevention, but since this is a crowd somewhat familiar with public health, I think I could be a little more specific. And actually what we do is really more of an epidemic control model within public health. And so really, the founder of the organization, he worked for the WHO for a long time. He worked on TB in San Francisco, AIDS and cholera in Africa. And so really what he did is he took that model and brought it to his hometown of Chicago, because he saw, not just, we were talking earlier about whether or not gun violence is an epidemic, and certainly the numbers is what we were talking about. The numbers making it an epidemic is such huge numbers. But actually what you find is gun violence really operates like a disease. It clusters in areas. You have a transmission of violence where just by observing violence, your risks jump up by huge amounts, 30% in some communities. And so what we're doing is just taking the same methods that we have tried for decades, and we have been successful in controlling epidemic diseases in Africa and other places, and we're just applying those same methods in Chicago and other areas. And so what I've been doing with the organization in the last few years is we've really been trying to expand our approach and kind of find new innovative ways of doing things. You know, similar to Joel, we've operated a hospital program where we go into emergency rooms and we identify people who are at risk, and we treat them there on the scene, where we meet them where they're at. We have various different school programs that we're piloting, and so really what we're trying to do is just look at all violence as an epidemic. And I think right now what you have is you have a lot of silos of people working in child abuse, you have people working in intimate partner violence, you have community violence, you have suicide, war violence. But when you start to look at violence as an actual epidemic disease, you see that all these types of violence are actually very much related. And so exposure to any kind of violence can lead to perpetration of different types of violence. And so what I've been trying to do just with our work is just find innovative ways of approaching this and breaking down these silos.
Hi, my name is Kathy Hempstead, and I spent a number of years working for the state of New Jersey in injury surveillance, and I was lucky enough to be working there when the CDC began a very innovative and new kind of violent death surveillance system, which I worked on for a number of years. And I guess I have a public health perspective on violence as well. It's not so much an epidemic perspective as it's sort of your traditional injury surveillance system, because in fact this system was really modeled after FARS, which is a pretty well-known motor vehicle fatality surveillance system that has been, thought that it's contributed a lot to reduction in motor vehicle fatalities. So I guess I'm really going to emphasize what it was like to be sort of, actually doing this kind of injury surveillance work with the violent death reporting system in a state, and what it was like to try to transmit the things that we learned to other folks.
So it's a somewhat artificial distinction that we put the last panel as the research panel, and this panel is the best practices panel, because you're all researchers, but we had to divide it up somehow. But with that said, I think what we'd like to do is drill down a little bit and talk about some of the best practices that are out there in light of some of the research challenges we heard in the last panel. And so with that in mind, when we were talking by email and by phone about what we would talk about today, someone had mentioned the gaps in services, and that largely the response to gun violence is about police and gun control. But in fact, there's a big gap in terms of reaching those who are at risk. And we certainly heard in the last panel a lot about those at risk. And so I wondered if you, and I'll let you all decide who wants to take this first. When we say high-risk populations, who do we mean, right? Because I think maybe articulating that a little bit is helpful. When they're at the high risk, what are behaviors that we can look at that can be changed in those high-risk behaviors to reduce gun violence?
Well, I mean, there's certainly, I think, a lot of risk factors that you can identify. But I think one important point to make is that it's important to tailor those risk factors to particular communities. The last panel was talking a lot about how you have small cities that have certain types of problems. We have a real problem with gun violence, but those problems are going to be a little bit different than the bigger cities, and certainly rural areas are going to be different. But you do have a lot of commonalities. So, people that have had arrests for gun violence before. These are people that we need to pay attention to. People that are involved in gangs or are involved in illegal selling of drugs or things like that. And people that have been shot before. That's one of the reasons why we locate ourselves in hospitals, because when somebody's been shot, what we find is that is often the staging grounds for the retaliation to that shooting. And so if we go to that hospital, what we end up doing is we end up talking to the family and the friends and just cooling down the situation. And so I think there's a lot of common risk factors like that. But the key is really, I think you can go to any community and you could talk to police officers, and they can give you a list of people that need somebody to help them out, somebody to work with them, to prevent them from, and they'll tell you, you need to work with this person to prevent me from having to work with them, because then they'll be going to jail. You could talk to teachers, and they could identify people, using these risk factors, using just their experience in dealing with people every day, and they could identify the people we need to work with. But the problem is a lot of times the services that communities are offering aren't reaching these people, because frankly, these people need a lot of, sort of help getting to these services. They don't know they exist. If they do know they exist, a lot of times they might have some biases against working with a government agency or going into some kind of government office because of their experiences with the government, some very legitimate experiences that bias them against that. And so what communities really need, the gaps in services that we were talking about, I think, was really linking up services that are effective in our communities, and instead of just having them deal with people that might have just a drug problem, have them deal with people that have a whole history of issues that can decrease their risk level of perpetrating gun violence.
Do you want to talk about that?
Yeah, I mean, I think Charlie brings up a number of good points. I think the first one you mentioned is the risk of re-injury after a visit to the hospital for violence. And we just published last year a study looked at just the kids that come in after a fight, not necessarily gunshots. And, at CHOP, we're blessed in certain ways that, a lot of the, I don't know how to say this, that's the wrong way of saying it, but many of our fights are not resulting from firearm injuries. They're schoolyard, street fights. They're kids that are going to be the ones who are at risk for gun injury in 1 to 5 years. And so we looked at those kids and found that 20% of them, 1/5 of them, when we looked at their original fight that they came into the emergency department with, had another altercation based on that event. And so if we ever sent anyone out of the emergency department with a 1/5 chance of having the same exact thing we just treated them for, I probably would lose my job in any other public health or health issue. So that's an important distinction, is that the younger kids and the kids that we call at risk, definitely a violent event is, even if they're in complete denial and or they really were in the wrong place at the wrong time, which does happen, they're still living in a place where this happens. And so the risk itself is not just a behavior on their part, but it's simply the environment in which they're having to travel. And we have to recognize that, so that they're dealing with the trauma every day, even if they're trying to stay out of it.
So you've identified ways to identify the kids who are at risk. So when you talk about the services that you provide, what services, can you flesh that out a little bit?
Well, I was going to mention that, in our violence intervention program, we do try to hook kids into other services and tie them into counseling if they need it. There's a lot of bias against going to a different part of the city or going to a counselor when, in fact, mental health has got its own I'd say stigma attached to it. So the services do exist. We have a lot of trouble getting kids into mental health care, even if they're willing to go, and we can bring them there. We literally, one of our services for our transitional counselors / social workers / whatever we want to call it, our person who's hooked into that kid cannot get them into mental health care. So that's one big gap. And it's not just insurance issues, it's capacity on the part of the healthcare or mental health care organization. And I think the other gap is something that Charlie alluded to, which was the lack of trauma-informed approach to our kids. So when they do contact the courts, the mental health or health care, or any place they have to go afterwards, people are treating them in a way that blames them. And it continues to traumatize the kids who have already been traumatized. So I think one of the ways that we can help is by looking at the systems that exist and kind of teaching or helping the frontline folks who are in contact with our violently injured kids, adults, to understand the trauma they've been through and deal with it in a more informed way.
One of the things I heard in the past panel that I want to push back on a little bit, one of the questions was about the title, about the culture of violence. I think there's a book, The Code of the Street by Elijah Anderson, which is a really seminal work. And then, other researchers like Deanna Wilkinson who have done a lot of work on this, where in some communities there really is this norm where if something happens, somebody disrespects you, you're expected to act violently. So, I mean, there is this I don't know, maybe we shouldn't call it a culture because it's a loaded term, but there is this norm of violence that must be followed according to some people's eyes. Like, so that, you know, if somebody says something to you and you don't act violently, if you don't get back at that person, you'll be seen as the next victim potentially. You won't have the same standing in the community, or at least that's the way it's perceived by the people, some people in the community. And so, like, one of the gaps in services, and one of the things that we can do, that we are doing with Cure Violence and with other programs like ours, is we're really providing a service to the community where we can help people back away from conflicts. So some of the work that Deanna Wilkinson has done has shown that actually a lot of the people, a lot of the kids that are committing these violent acts, if you talk to them, they don't actually want to be following through with this violence. They would love to have an out, but they feel like they have to. It's expected of them. They are doing what they think their friends expect them to do. And so if we have workers in those communities that can act as trained conflict mediators, they can give an out to these people. They can give them a way to step back. They can use conflict mediation techniques to cool down situations. And, you know, they could tell a person, you know, just, you know, leave this to me, I'll settle this with this other person so that you don't have to get back at them. And so I think that's one of the ways in which we can really easily create a situation where you don't have to follow this norm. You don't have to follow this culture, or whatever you want to call it, of violence that is in some communities.
Yeah, thank you, Jim.
I would say from our vantage point, one of the things that we always noticed was that for all the different kinds of firearm fatalities there were so many different populations that really had different kinds of service needs. So one of the things we dealt with a lot was suicide, and when you would read the narratives describing the situations and read the different circumstances that were associated with these acts, we would definitely see some real opportunities for prevention. And one of the things that would come up so often would be an elderly man with declining physical health who wasn't necessarily terminally ill but had really seen some reduction in his quality of life, and, you know, shortly after maybe finding out that his vision wasn't going to improve or something like that, you know, we find that he's committed suicide with a firearm, and there seems like there's a real opportunity there for his physician and his family members to maybe be thinking about the fact that this actually happens a lot, and if there's a firearm in the house, this might be an opportunity to remove that firearm from the house or for someone to inquire about it. Another thing we would read about a lot would be an adolescent male, a young person maybe gets in a very explosive fight with his parents about, it does tend to be males most of the time. That was one thing they had in common. You know, loses the car keys for a week, or gets in trouble for bad grades, something like that. You know, 15 minutes later, literally, you know, everyone goes out, he finds the gun, commits suicide. So you see a lot of times things that make you realize these events are so preventable, because the impulse to commit the act is often really doesn't have that long a duration. And it's really one of the things that I think, you know, the public health perspective that we emphasize a lot is the access to the firearm is, you know, so often really the problem. And if there was a way to kind of anticipate some of these things and separate people from their firearms, it would make a big difference.
And again, just to drill down a little bit on that, when you say to look at prevention and separate them from their firearms, who, in terms of the different models that you have, is it really the healthcare professional? Or, I mean, what are the models of doing the separating, identifying, but then also separating?
Well, I think that's a great question. I mean, I think in the context of suicide, you're really dealing with people who are using their own guns that they legally purchased, or their parents' guns that they legally purchased. Most of these people are not psychotic. They wouldn't have failed any kind of background check when they purchased their firearms. So there's, you know, when you sort of think about gun control and sort of the flow of guns into people's houses, you know, I think a lot of times what we acknowledged is that people already have access to weapons, you know, so you're kind of dealing with a population that has access to their weapon. So then I think there's a real opportunity for public education, and I was, you know, thinking about what Governor Florio said, educating the public, but I think there's also an opportunity to educate people that own guns to think about those risk factors. And in fact, there is some work in that area that's going on, not so much in New Jersey, but in some other states where departments of health are really reaching out to gun shop owners, gun owners, and sort of saying, you know, I'm not trying to say anything about your right to own a gun, but let's acknowledge that sometimes it really is dangerous for you to have your gun in your home, and there may be some times when you would really be better off to remove your gun from your home, and giving out gun locks, and people are putting up posters in some gun stores. This is not a mass movement yet, but I do think that is that is a helpful direction for things to go, because frankly, nothing in gun control or background checks is really going to stop the fact that a lot of people, we've done some studies in New Jersey, and others have too, that look at how often people buy a gun right before they commit suicide, and the answer is almost never. So the guns are there, so it's more of an education opportunity.
I think that the analogy that I use is the culture of safety that we've established in the hospitals, where it's okay to ask and it's okay to question, it's okay to report without fear of retribution. And it's not just in the medical community, but we talked a little bit about it at the last panel, where the medical community has been challenged in its ability to ask about guns in the house. And we ask a lot of things that are very intrusive. I don't want to mention some of the things we ask about in public, but we ask about them in private, and it's okay to do that. But there's the schools and other places that people congregate, and other places that can see where someone is going down. Those are that culture needs to change, where it's okay to say, I'm worried about this person, and try and get whatever support is needed. It can't be a silent, he's acting weird, but I'm going to ignore it kind of thing. So that's really, for suicide, I think, a different approach than we're talking about for homicide. Bill mentioned 3 different types of kids. The kid who finds a gun, the kid who's angry adolescent, and the gang member. And I actually think that's true to a sense, but it's also, I think the 3 are tied together with a common thread, which is fear. The gun is in the house usually because of fear, at least in many of our inner city homes. It's not for hunting, it's not for sport, it's for protection. And if you ask people why they carry a gun in the city, it's for protection. And if that fear was removed, meaning if there's not the need for protection, then you don't need to escalate your firepower in your home. The adolescent is carrying a gun because he's afraid that if he doesn't, he will be hurt more. And the gang member fears the fact that he has no one else in his life except to join. The caring person in his life is the people who are in his gang. It's usually not an economic decision. It's usually a relationship decision. And so I think there's things that tie together all of these aspects of violence.
Mm-hmm.
I think you had mentioned some school-based programs. Did you want to elaborate on some school-based? You had mentioned some education programs that were going on.
Sure. Well, what Cure Violence is doing with education programs, school-based programs, is, really, the key to, I think, the epidemic control model that we have is there's 2 keys, and the first part of it is detection. And so we're really looking at detecting events, so finding out when gangs are having a war, finding out when one person has a problem with another person that might turn into a shooting. But it's also a matter of detecting individuals who are at risk. And like I said, some of the people are police officers who can tell us this. Sometimes it's family members, and sometimes it's teachers. And so what we've done is we've located outreach workers within schools. It would be similar to what you would have as for maybe a guidance counselor in a school or some other person playing that sort of role. But I think the key difference here is the people that we're locating in these schools are, oftentimes former gang members. They're people that live in the community. They're people that can, they have somebody who is, high risk and who's being referred to them. Oftentimes they can say, you know what, I know your mom, and she would not be, appreciating what you're doing right now. And so the first part is detecting, but the second part is really being able to reach them. And you can't, like an example, an analogy would be, the founder of Cure Violence, he used to work in HIV in Africa. And when they were first trying to kind of change sexual behavior, they had their WHO workers out there going to try to change the behavior of people in these villages, and they weren't getting anywhere. So what they ended up doing is they ended up taking people from the village, training them very carefully, and then putting them out there, and then they could really have this change in sexual behavior. And the same thing is true with violent behavior. If you can't meet the people where they're at and talk to them in a very real way about what their problems are and understand them, then you're not really going to be able to change anything that they do, because they're going to immediately tune you out, because you don't understand where they're coming from, you don't understand what they're dealing with. But if you have somebody that does understand that, then you really can. And so schools really have just been sort of an entry point for us to meet these people and to detect them. But then the key is putting people in there, into the schools, not just your normal workers, but people that have very specialized skills.
Well, I'm glad to hear that fear of mother overrides everything.
Fear of mother.
Mother of 3 teens. So we've all been talking about people who are at risk, right? And sort of what the model is to identify people who are at risk, and then perhaps some situations. Is there a role for educating a broader public in terms of educating folks who aren't at risk, right? Who we don't identify as at risk either because they don't own a gun or they haven't exhibited, poor mental health or aren't ill or whatnot. Is there a role for that if we're looking at this from a public health model?
I think there absolutely is, and we call that, universal prevention. But I think what Charlie mentioned as far as the concept of what is normal, and changing the normal involves changing the entire population's view on something, and not just targeted group that you think has the problem, therefore it's not my problem. So we should be working on all 3 levels of, find universal education around certain items and topics, and just changing that culture, so to speak. The targeted one where it's, you kind of think that this person is more likely to do something and therefore want to make an intervention, and then the ones that already had trouble, who are definitely at high risk and need the support more specifically. So I think those 3 levels are probably what you're talking about that Ceasefire is going for in all its efforts, and many of our efforts are targeted at those levels.
And part of changing the normal, like you're saying, is you don't necessarily need the people that aren't high risk to change, but a lot of times you need them to speak up and just say that, I'm a member of this community too, and you know what, this actually isn't the community norm. The community norm is this, but you just don't realize it. But if they're not speaking up, then the high-risk people don't hear that, and they don't realize that. And I think other panel was getting at that too, is we really need people to be more active, and that includes at all levels, whether it's the actual inner-city community that is having issues with gun violence, or whether it's further out from that. But it's a matter of people speaking up so that they hear what is actually normal, because really what people perceive as normal is just what they hear.
And the media plays into that, and it has a role in it, if we can call upon that group as well. I mean, I remember we were in a session a year or 2 ago with teenagers who, around the issue of flash mobs in Philadelphia. And one of the statements that really stuck with me was a kid who said, everywhere I look on TV, they're showing us acting like animals. If they want me to act like an animal, I'm going to act like an animal. But he didn't want to, and he wasn't going to until that. So.
Another thing I think that's worth thinking about is, in the area of suicide at least, I think for many people there's sort of a fatalism, of if somebody wants to kill themselves, they're going to kill themselves. So, who really cares about trying to restrict people's access to lethal means? It doesn't really make any difference, And I think for some people that is true. I mean, there's people who will drink antifreeze, set themselves on fire, but that's a very, very small proportion of people that commit suicide. So I think one of the big achievements that's come out of a lot of surveillance about injury, particularly suicide, and choice of weapons, so to speak, is that it really does matter whether or not somebody has access to lethal means that are very, very easy to use. And there have been a number of interesting experiments, or not experiments, but things that have happened where people have looked at the impact of removing some kind of toxic chemical from pesticide, or removing some other, lethal element from the environment, and looking at what happens in trends in suicide rates by that method and by all other methods. And you see an absolute decline in suicide and not a lot of substitution to the other methods. So I think, the same thing, people have applied it to thinking about creating barriers around places where people want to leap, and have found really the same thing, that it really makes a difference if you can prohibit people from jumping off the Golden Gate Bridge. It'll actually reduce suicide, absolutely. And one of the most powerful pieces of evidence that gets brought to bear is interviews with people who survive very, very lethal suicide attempts and actually describe how short-term and impulsive their suicidal plan had been. And I remember the New Yorker actually did a great article about this a couple years ago, and probably a lot of you have heard this, but there's a great quote from a guy who jumped off the Golden Gate Bridge, and he said, "As I was falling through the air, I realized that all the terrible problems I had in my life could be fixed, except the fact that I had just jumped off the Golden Gate Bridge." But in fact, he did fix that problem because he lived, but that's really, really important evidence that restricting access to lethal means really does matter. And so I think that's something that people in general tend not to think about, but really should, so that when you see somebody who's acting troubled or acting really down, like, it wouldn't be crazy to wonder whether or not they had access to a firearm, because that actually might make a difference in whether or not they hurt themselves or someone else.
And so similarly, we, on an individual basis, can teach kids how to move from the epinephrine-laden part of their brain to their frontal lobes in a way that, some either deep breathing or thinking about something else that can actually move them from that impulsive event where someone wants their sneakers and they're about to kill them, to giving them their sneakers and thinking about living. So there's these impulsive acts that I think of the second group that Bill was talking about are really the ones that we can have some deep impact with very sustainable, small kernels of interventions.
So just to push that a little bit, though, because we're sitting in a policy school, how do you scale that up? So who imparts that wisdom to these kids, and how do you scale it to a sense so that then you have a policy and not just a, and I don't mean to be pejorative about it, but not a one-on-one interaction with that kid?
Yeah, I mean, scaling up is definitely the challenge. I mean, with Cure Violence, we had initial success in Chicago, and then the challenge was, okay, you've done it there. Let's replicate it other places, and that's really the challenge with any social science intervention. It's because when you go to a new environment, you have different people implementing it. You have different things going on in the community, different understanding of what the program is, and then people always bring their own baggage with, this is kind of what I think works, so I'm going to interject this into it. And with Cure Violence, we've had programs that have replicated our program, have been very successful, and then we've had programs that have replicated, and they've done a few changes and done things their own way, and they've actually caused increases in gun violence. So it's really crucial to implement it right. And so some of the things that we've learned along the way with our successes and failures are that, I've talked about like the need for hiring people from the community to do this work. Because you're doing that, what you end up needing to do is a lot of training and a lot of technical assistance. And so what we do, we're working right now in Philadelphia and Baltimore and New Orleans, and in Philadelphia, it's a new program, and we're just kind of getting off our feet. And we've had workers from Chicago out there for weeks at a time. In Baltimore, when we first started off, we had one of our trainers move to Baltimore for a month so that he could work with the people we were employing and actually, talk to them about all the different hurdles that they were going to face. And so it's pretty, in our experience, it's been pretty work-intensive experience to scale this up. But I think as you grow and as you learn these lessons, you start to get a curriculum for how you train people. You start to establish some kind of protocol, and I think on a program-by-program basis, that's what programs do, is they just kind of figure out through their failures and their successes about when they're ramping it up what actually needs to happen and what is just something that can fall by the wayside.
I mean, at the risk of maybe asking a very basic question, is success simply a reduction in gun violence? I mean, what's your definition of success, and how do you measure it?
Well, typically when we're looking at success, we're very specific about what we're addressing. We're addressing gun violence. So, as opposed to drug addiction rates or other community factors, the way that our program looks at gun violence, and this is one of the things that really drew me to gun violence before I started working in the program, is gun violence is really, I think, one of these primary issues where, cities struggle with schools and they struggle with poverty, but gun violence is really kind of the primary issue that's causing a lot of these problems to be so difficult to overcome. So in other words, you can do all sorts of changes to schools, to inner city schools. You can get new teachers, you can develop new curriculum. But if that school still has a violence problem, then you're going to have kids that are too stressed out to learn. You're going to have kids that don't even show up to school because they're scared to go to school. If you have a community, you could invest a lot of money to get business development. But if you still have a violence problem, then what businesses are going to move there? And the businesses that are there, what would they invest to expand? So violence is really, I think, the primary issue. So when we're looking at outcomes, we're looking at gun violence rates, and then we're looking at things that directly influence the gun violence rates. So things like attitudes about gun violence. So a lot of what we do when we look at the evaluations of our programs, we do surveys to say, is it okay to use a gun if somebody insults your girlfriend? And so over the course of time, hopefully we'll see the people that say, yes, it is okay to do that. Hopefully we'll see that rate go down, and that's what the intervention is designed to do.
Phil, did you want to take that one? Or your definition of success?
Yeah, I think that depending on the age of the child, I think, and the age of the person that you're dealing with, gun violence, if you're working on an individual basis or with these programs that do work with individuals, it's really hard to move the needle in the city on gun violence because you are working with a few kids, you're changing their life, but you're not necessarily working in so many different areas. So when you're thinking about scaling up, you want to be very careful about how you're replicating it. As an example, we have a national network of hospital-based violence prevention programs, violence intervention programs that we try and establish best practices among so that we know what may not work. We talk to each other about what's working in every other person's community. We think about how that may work in our community, and we try and use Charlie's model of, doing and acting, and then I'm Charlie Brown, it's not Charlie, of doing and acting and measuring and kind of seeing what happens in your community. Sharing and forming that coalition has really helped us and all the other programs, the 20 or so programs that are around the country doing it. That said, I think there's some benefit to funding the research that we're also doing, and Dr. Leff is over here doing it in our institution, about how to best replicate something with fidelity and integrity so that you don't have to repeat the entire program the same way, but how do you figure out what the community members need to do to maintain your program by themselves without you there, and what's important and what's not. And if that's the only way these programs can be sustainable is if the community adopts the program themselves, and with a little bit of help or maybe some more, depending on the community, it becomes part of what they do, part of the school, part of the recreation center, as opposed to us eggheads coming in and deciding this is what they should be doing, and we'll help you throughout the whole thing.
Kathy, did you want to take on the...
Well, I think, some of the kinds of policies that I think would be helpful would be to really try to affect sort of a culture change among particularly people that own guns, but just about guns in general. So that, I think everybody knows if you have an adolescent male in your house and he's driving your car, you're at higher risk, and your insurance premiums will reflect that. And
I own one of those.
Exactly. And so maybe there's not really a viable sort of liability, price model for this, but I think there could be a growing awareness that, if you own a gun and you have, who's in your household? Do you have anyone at high risk in your household? And maybe you periodically ask people that have gun licenses, who's in your household now? Are you aware that, these are people that are at higher risk for using your gun? I also think, buyback programs, I think everyone loves to see the big pile of weapons, and I think New Jersey actually has a smart buyback program, and they've confiscated over 10,000 weapons, including a lot of, really scary weapons. So that's all great. But I think ongoing, there should be a way for people to know what to do if they want to get a gun out of their house, maybe temporarily or maybe permanently. And I feel like there should be a way to support families in trying to do things to make themselves safer. And I don't think right now that's really there. So I think on the suicide side, I think those would be the kinds of ways to sort of further a means restriction agenda that wouldn't, necessarily be so anti-gun that it would, create a lot of, defense. And meanwhile, everyone stockpiles weapons while you're debating gun control. But I think just a way to encourage a more responsible kind of gun ownership. And I think that's, something that everybody could benefit from. On the side of homicide, it tends to be that means restrictions policies are more designed to get people to leave their guns at home and not carry them around with them, because most of those events occur sort of outside in public places. So stop and frisk, which is super controversial and unpopular, but that's one of the things it's for, I think, is to kind of get people to be less likely to have their guns on their person. But I think it's much more difficult for me to think about means restrictions activities that are as clear, in the case of homicide. I think with suicide, some more things come to my mind, but, I certainly think that that's an area where some creative policy would help.
I mean, we're labeling this best practices, but I wonder if sometimes it's helpful to know what doesn't work, sort of the Berenstein Bears approach to gun control. So I wondered if you, in all your work, if you've seen people who are, practices that are well-meaning, but really you would say is a waste of public dollars or a waste of dollars in terms of not being very effective in terms of changing behaviors.
Well, I mean, I could talk about the programs that have tried to replicate the Cure Violence model and failed. There was a program in Pittsburgh called One Vision, One Life. So the reason why they failed, I referred to them as having an increase in gun violence. And the reason why that happened is when they were hiring the workers to work with the individuals that they identified as high risk, they identified people that were associated with the church that was helping to implement the program. So it's like basically church congregants, which nothing inherently wrong with that, but these church congregants did not have the access to the high-risk individuals. And so what they ended up doing was they ended up working with people that had serious drug problems, and they would help them to get, drug treatment. Or somebody who was unemployed and needed a job and was really having a hard time and down their luck, they would help them get a job. And so they were doing good things for the community, but if the ultimate goal is decreasing gun violence, they weren't doing anything that could even be expected to have any effect. So you're not going to affect gun violence unless you're dealing with the people that are actually most likely to be committing that gun violence. And so that sounds simple, but it's actually one of the most difficult things, because the temptation when you're an outreach worker, the temptation is, this person needs help, I want to help them in whatever way I can. And it's hard to say, you know what, I don't have time to help you. You need to go find help somewhere else, because I can only work with people with this set of criteria. But that's what needs to happen, and when that doesn't happen, then you don't get the decreases in violence. And one of the reasons why it occurs is because the very high-risk individuals are not really touched by very many programs at all. A lot of times they're not going to school. They're usually not involved in churches. So they're just going about what they're doing, not being touched by anything. And so if we don't have a program that actually reaches them, then nothing in that community is going to change. The second thing I would point out in terms of what causes some programs to fail, depending on what your metric is. If your metric is a community-wide decrease in gun violence, I think like you were saying, Joel, there are a lot of interventions that can help the individual. They can put that individual on a better path and solve whatever issues that individual is dealing with. But when it comes to community-wide change, there's a lot fewer programs that do that. And so what's important with doing that is, one, having that as your goal, is targeting the community. You're not trying to help individuals. Maybe you get there by helping individuals, but your goal is to decrease gun violence in the whole community. But then the second way is to address the whole community. What we do with Cure Violence is we have events, we have marches, we have public education. We do things community-wide to change the norms around gun violence, to give people a voice, to give people roles to play so that they can be part of that. But what it's doing is it's creating a community-wide effort. It's really a real community movement, in fact. And so I think that's what we see in terms of our replications, is you have to have that focus on the entire community.
I think that I agree with all of that, and I think that one thing to add to programs that don't work is if your program or your intervention is based on fear and shame, then it will not succeed. So an example of that is Scared Straight, but it's the whole gamut of that kind of program.
Kevin, did you have something to add? No.
Well, I think, they're kind of unavoidable, but these sort of place-based police surges, Operation Clean Sweep or whatever, I mean, there's imperatives for doing those things, but I think, they tend to, it's sort of like squeezing a balloon, and it just pushes activity to another place. And
So I think we can open it up to questions if we want to come on down.
While we're talking, can I just add
Sure,
one more
yeah,
thing to
yeah.
that, which I think one of the problems with doing this kind of work, and it ties in both the research and implementation folks, is a need for short-term outcomes in funding. And we know that when especially for those of us that work with children, it is really hard to show outcomes in less than 5 to 10 years,
Yeah.
because those are the kids that we worry about when they get to high school. And the expectations of both our politicians and oftentimes our politicians and our funders is that we showing outcomes within the 3-year grant period.
Right.
And just to echo that, I mean, our experience, we've had that same problem where in the last 5 years, we've had in Chicago 3 interruptions in funding. And so, not only do you not have the long-term work with an individual, but you also have an individual who's being picked up and saying, I'm going to help you, and then dropped. And then, maybe when you come back to him, maybe he'll sign up again. But if you drop him 2 or 3 times, that individual's not going to come back to you, and you're going to lose them.
I would also say I think it's so hard to evaluate all of these different place-based programs because there's never really a control community that you can look at, and there's all these other things, whether you're talking about Stop and Frisk or Operation Ceasefire or any of these programs, and people pour a lot of money into evaluating them, but it's really, really difficult to know.
I think it's why we had started by trying to say, well, what's your definition of success, right? And if you need to prove that.
Right.
I think it's, sometimes you define success and then
You
back end into
find
proving.
intermediaries to as your success outcomes, because those intermediaries in other people's research have shown to reduce violence, but you're not actually changing the violence with your outcome at that point.
Did you have a question?
Yeah, first I want to thank Charles for not mentioning the failure of Cure Violence in New Jersey.
They actually didn't, they would be one of the ones that did not implement the model correctly.
I understand, but I want to try to address these 2 points that I think both of you raised, and that is that kids don't like violence and they'd avoid it if they could, and this norm of retaliation. And I would add to Elijah Anderson the work of John Rich, who's written a couple really brilliant articles on the meaning of sucker or being a punk. Mm-hmm. And I think the way you understand both those occurring simultaneously is that the kids live in an environment where they're not respected at all.
Yeah.
So the need for respect and the way to get it is through the retaliation in their community. So I think it's a natural outcome of that disrespect and lack of access to opportunities is the way you resolve those two. But I think the way, and this hasn't been mentioned yet, for me, the most exciting trend in all this, and it links this, is to focus on the youth themselves in terms of getting them involved in community organizing, because that gives them an opportunity to contribute to the community. It's relatively inexpensive. In Philadelphia, you have the Philadelphia Student Union, which isn't necessarily addressing violence, but they can affect what goes on in the schools. And there's a great pride they take in the effects they can have in the community, and it shifts the balance so they can get respect from the community in other ways. That said, I think we have to really help the community start not to stigmatize its kids. And that's done through the media, And I think you're right, Joel, that when the kids see this on television, but they also see it in their communities where store owners shoo them out. And in many hospitals, not yours, because I know how you guys work, they're viewed as animals. And John Rich, again, has a book which talks about this and his experience in Boston.
Yeah, I mean, I think that's definitely a good point and good ideas. One thing I would point out, though, I think when we're talking about the highest risk individuals, trying to engage them in doing community building activities might be a little difficult because they already have so many issues that they're dealing with. You know, they need their drug addiction dealt with. They need, you know, they might need you know, some anger management classes in order to really be able to contribute to their community. The people that the Cure Violence program deals with have a lot of issues, and it takes months of work to even figure out what their game plan should be to get them to move from high risk to medium risk to low risk. You know, but at the same time, you know, I agree with you that this sort of internal, organic building of the communities from within is something that needs to happen. And I think, you know, we need to come at this problem from all different ways. And so we need to address the very high risk. We need to make sure we do that. But we also need to make sure that we do things for other people and that we provide other ways for people to have and get respect that they need.
I agree. There's an article by Joyce that looks at successful police interventions for communities, and the communities that do the worst are what Joyce refers to as anomic, and I think it was mentioned last. There's no community base to help the police, because you cannot, as most criminal justice folks will say, you cannot police your way out of this problem, and if there's support given so that environmental changes that Charlie Brannis was mentioning and other support is given to a community that is not necessarily seen as violence prevention, right? So we think about, you have to stop thinking about this in silos, then that community will more likely have the ability to remove themselves from that anomic, we don't have a name, we're just people living in our houses and we're not really talking to each other, and start working with the organizations that are there to support them.
Hi.
Hi.
I've enjoyed the discussion. I'm wondering if we can take these best practices and translate them up a level to a bigger policy issue. For example, I haven't seen any detailed research, although I know some from the law enforcement literature, of the effectiveness of carrying a weapon for self-defense. Doesn't work very well. More often than not, the weapon is turned against the owner. There's a lot of data around that, but I don't see that promulgated in research as part of the argument. Some of the myths that surround violence. The second thing that is disconcerting is the mental health constraints. A lot of the debate has been about let's restrict people who have mental health issues, and we haven't heard much about that in terms of is there best practice, but there certainly is a lot of public support for that. And finally, and the Congressman, I'm sure, is going to talk about it when he gets up, the issue of suicide. Is suicide a common ground? Because we have kids committing suicide impulsively, because we have wounded warriors, we have the highest suicide rate amongst returning veterans in our history. Is this become the common ground where someone who is even a proponent of having a weapon, says we have to have some reasonable way to constrain people's access to something that's going to do harm to somebody who served us or a child that we love? Is there an opportunity here to use research to support the type of thing? Trying to move the ball down the field, is the opportunity rest here? I think it does rest with best practices. How do we get there from here?
I think the suicide question is yours, and then I could answer some.
I do, I never thought about suicide as being a common ground before, but, there is sort of a broader constituency of people that is affected by suicide. So I think if you really can convince people that having access to a firearm has a significant positive effect on the probability of suicide. I mean, I do think that's a way to kind of nuance the gun control discussion so that, you know, even people who like to own guns and are gun owners can acknowledge that, you know, sometimes it is not safe for there to be a gun in my home. And here's what I do when that happens. And I think all that part is sort of missing. But I think some people are starting to talk about it, but I think we do need to do much more.
I wonder if, in the same light, gun accidents might be another neutralizing ground. I mean, you know, there have been a couple high-profile accidents of kids playing with guns, you know, and I don't think even the most fervent gun owner thinks that that's a good thing, right? It might be another neutralizing place. Did either of you want to?
Yeah, I mean, I'm not sure that, I think people who commit suicide are often blamed for their own problems.
Yeah.
And I don't think that the only reason that the Connecticut tragedy motivated and moved our whole nation was because it became a "it could happen to me" phenomenon. And that's what moves nations around this issue. And unless someone has had a direct relative or someone they love or care about commit suicide, which of course many of us unfortunately have, I don't feel like that's the media campaign around gun ownership. I'm not sure it would work. I'd love to hear other people's opinions about that, but I just don't, it doesn't resonate as much as 20 school children, which of course is not what we're talking about in the inner city either, but we're using it to help everybody. So in a way, I feel like I think studying it would be important.
Oh, sorry to interrupt.
No.
I mean, I feel like it's a little bit of the same issue, though, because I think in terms of maybe someone in your household that gets access to guns, and maybe they don't want to hurt themselves, maybe they want to hurt a bunch of other people, and then hurt themselves. Because I think a lot of times those multi-victim events really are just very, very elaborate suicides that end in the death of the person perpetrating the violence. So I think that same kind of awareness and safety issue could be brought to that issue as well, because a lot of those events are perpetrated by young men who are not necessarily owning all their own firearms, but they're getting them from a parent or an older relative who could be a little bit more aware of some of the risks.
In terms of moving the ball forward into policy, regarding mental health, I feel like with these mass shooting events, or really suicides is what they are, not in every instance, and maybe not even in most, but in some instances, there have been people in the community that have known something was up with these individuals. Mm-hmm. And they've known that this person needs help, and if they don't get help, something's going to happen. But they never did anything about it. And so, but I think the question you have to ask is, well, what could they have done? And, calling the police would be one option, but, people they're going to really resist calling the police on somebody. There's a stigma to institutionalizing somebody, and if that were even a possibility. So I think what you see there is there's a real gap. If people have identified somebody that they think is going to harm the community, there's nobody for them to turn to. So I feel like there's a real need in our country for community health workers, people that are embedded within a community, who people can turn to not just with gun violence, but can turn to with other types of diseases or other health risks. And some communities have these, and certainly there's public health offices in different cities and counties. But I feel like embedding health workers in communities can really go a long way towards giving people an alternative, giving people something that they can do to stop these events before they happen.
Mm-hmm.
Thanks so much for taking the time to share your work with us today. One question that came to mind that has been referenced a couple of times is that males are at higher risk. And I was wondering if you can comment on either the differences between males and females in the risk factors for gun violence, and how our community programs can ensure we're targeting both females and males.
Unfortunately, I think the differences are becoming more, they're less and less different for girls and boys. In our clinical work, when we looked at the 600 kids or so that were injured by violence, 40% were female in our hospital next door, and it was fighting. We did some studies looking at gender, and the one, and this is not meant for humor, but the one difference that we found with younger girls and younger boys was that the girls remembered, and their enmity lasted longer than the boys, who kind of like they fought and it was almost over, as opposed to the girls who were plotting and planning around a longer period of time. But other than that, it really wasn't that different. But I think there's the question that I would ask you guys is whether you think the interventions need to be, not the epidemiology, but the interventions need to be somewhat either gender specific or separated. We are finding, I think for sure, that the group sessions that you have and group discussions have to be gender separated, because there's a lot of showcasing involved with boys and girls. But I'm not sure what you're...
But we found that you definitely have to separate. I mean, we have outreach workers who are female. We have conflict mediators who are female, and they deal... I mean, they can deal actually with male or female successfully, but the issue we have is having male outreach workers dealing with female clients, and there's just a lot of, I think, problems that introduces. And so we have rules against that just to avoid anything.
But are the interventions different, or are they similar?
I mean, we train our workers, both male and female, in the same way. I mean, in terms of conflict mediation techniques, it's the same techniques, just you use the same means. In terms of outreach work and getting people to a lower risk level, it's the same means. It's identifying their issues. I think one big difference between males and females is how the norms are applied to them, the norms of the community. I think a lot of times what we find is, I think you're right that the females are more and more becoming involved in the violence, in community violence, but for a long time, and I think still to a certain extent, males are held to the standard of you have to respond, you have to retaliate, and females are to a lesser extent in the communities that we work in.
I would say, suicide is more of a male thing to do, and firearm suicide in particular is much more of a male behavior. When, sort of an impression of looking at differences between female and male suicides is female suicides tend to show a lot more evidence of really long-standing mental health problems and maybe prior attempts, and they're much less likely to seem very impulsive as compared to male suicides. Now, maybe that's because females in general you really have a lot of truck with firearms. And I do notice, sort of out of the corner of my eye, ladies' night at the range, and a lot of efforts by the gun industry to get females more involved in shooting and owning guns and stuff. So, it may be if we had this conversation in 10 years, which hopefully we won't have to again, but we might say, well, there's less of a difference. But right now, I think, guns are things that males use. So males are more at risk to the lethality and the way that guns are very amenable to impulsive behavior. So it is more of a male thing right now.
Okay. First, thank you all for really talking about these important things here within this forum. And I guess I just had a comment. I also do work in urban Philadelphia along with Joel. And one of the things that I feel strongly about, and I think, Charles, you alluded to, is the importance of empowering the community. And that being, taking the community back, but also providing training. And then I think it gets really complex because it's not just the training, because we often hear that in the community. If we had more money, if we had more training, but it's what to do. And so I think that's where the best practice programs come in. But it's even more complex than that, because the program has to be matched to that school or that community, such that it's developmentally appropriate, culturally sensitive, and then implemented as appropriate. Because I think when any of those things fail, community is not engaged, community is not provided with training that can sustain efforts, a program that's chosen that doesn't have a good research base, or what we often don't talk about, the program's not done with fidelity. So it's not really that program anymore. When any of those things fall off, I think that we have the possibility of actually taking a step back instead of a step forward, And I think that's why forums like today are really important, to educate folks that all of those aspects are a piece of this. So anyway, I'm going to step back, but just wanted to hear if you had any comments about that.
One thing that comes to mind for me, I mean, we've been talking at Cure Violence a long time about how can we get the community to do some of this work for us. You know, it'll make the program more sustainable. It'll empower the community. But one of the things that we've really kind of has caused us to hesitate a bit is, you know, preventing gun violence is dangerous work. And so, you know, it's not just a matter of providing a sort of cursory training to say, okay, if you want to talk somebody down from a gun violence incident, here's what you say to them. There are a lot of dangers involved, and so we've been kind of hesitant at doing that because of that. But I do think that there are other ways that the community can be involved, just by, you know, being there. And a lot of the problems that the communities that are experiencing chronic violence have is people are afraid to even go outside. You have a lot of people who use the back door and they go to their garage and they drive away. They never actually step foot outside their house. And so just empowering people to be out in the community and be an influence on people who need that sort of older adult influence in their lives is important. But I do think you have to be careful because I mean, we're dealing with guns, and it's very dangerous work. And so if you start empowering the community to mediate conflicts, and they feel like they can do this, and they all of a sudden find themselves in a situation that they can't handle, I don't want to be the program that's responsible for that. So you do have to be careful.
I think we'll take these last two questions, and then we'll wrap up.
Thank you for being here. I work with the state medical examiner. So to put in some context of just numbers for New Jersey specifically, there's about 411 or a little over 400 homicides a year in the state and about 700 suicides. About 80% of those homicides are gun related. The suicides are a little bit different. About 45% of them are actually hangings. And then about 30% are gunshot wounds. And I think the suicide piece, I think, is access. It's a function of access, where New Jersey has some strong laws here. As far as the overarching policy question, I think that a lot of the literature talks about the family structure as a place where that can be built up. The areas of education, economics, housing, healthcare, and criminal justice, and those families being a filter for those young people. That's why mentorship works well. That's why extended days in school work well. That's why early morning breakfast programs at schools work well, because they mimic family structures. To the point of Cure Violence, and I applaud Cure Violence. Cure Violence is an acute intervention program that allows for that interrupter piece. So you don't want the community doing that. But there's a lot of violence prevention activities in building up homes that we heard in the last panel, and building out community service projects within that particular community. So there's a lot of work that the community on the ground can do. The question that I have for the panel, just to discuss if you can, is really the role of larger governmental type constructs. Illinois has a violence prevention authority that's set up between the Attorney General and the Public Health Director. And there's the National Forum on Youth Violence Prevention that Department of Justice has brought together, a multifactorial, multidisciplinary board together to fund infrastructure development and violence prevention. Camden is one of the latest recipients. So I would like to have a little conversation about those particular larger structures that might be able to help the community get on board. Thank you.
And I think that the larger structures need to be listening to each other and be multi-systemic. And that's, the funding streams until now have been, in silos. Justice, CDC, they all take slightly different. I think, I'm sorry I didn't get your name, but what you were talking about sounds like a multidisciplinary approach where people are actually listening to each other and learning from each other, as opposed to taking a stand about what they think is right just because it's what they do. That's the first step. I don't think it's an easy fix. The city of Philadelphia has tried for many, many years to get the systems together. And only recently have we seen some real progress in that regard. So I think it's really a matter of good listening skills and being able to compromise on what your domain is so that you can move the field ahead.
Okay, you're the last one.
Good afternoon. I actually have two questions, if
Okay.
that's okay. My name is Tracy Swan. I work at Rutgers University in Camden at a Think and Do tank, and I work on a lot of public safety, violence prevention efforts. I was lucky enough to be the one, when New Jersey did their ceasefire version, to implement that initiative in Camden. I say lucky in quotes, because they took pieces of the Chicago ceasefire and pieces of the Boston ceasefire and put it together and then said, this is New Jersey ceasefire. So the model was flawed to begin with. But even with that, in Camden, we did see a reduction in shootings in the 3 neighborhoods that we targeted and no further displacement in the neighboring. So there was some good results from that. Unfortunately, in places like Camden and even in New Jersey, we've had changes in our attorney general, like we've had 5 different attorney generals in the last 10 years. We've had the same number of changes in the Camden County prosecutor and with the Camden Police Department. So it's been difficult to have some kind of sustainability around funding and around effort around violence reduction. So my first question, though, is for CURE, is what you're doing, if anything, with the police in terms of where you have this model implemented? Because I know traditionally it wasn't a model to really be working hand in hand with police, but I thought I had heard that had changed a little bit.
Yeah, well, so just a little background. I mean, with the model in New Jersey, the ceasefire, the Operation Ceasefire, that was very much a cooperation between the police, and the kind of the reason why we stepped away from that and said, you know what, this is not our model. You guys, good luck with your model. And you did have, like you said, you did have reductions. So I'm not saying that it was unsuccessful, but part of the reason is that what is really essential to our model is our access to the highest risk. And the way that we have that access is that we have workers who are hired specifically for their access because of their background, because of where they're from, the community they're from. And when those workers are seen as somebody who's working with the police, they lose their access. And so if you don't have your access, then we don't have a model that's successful. This is not a public health model that works. And so we've, consciously taken a step away from the police, and that's caused us some problems, but it's kept our workers safe, and it's kept them, having access to the people we need them to access to. So that's why we do it. In terms of what you're referring to about some changes recently, there has been some funding in Chicago that has come through the mayor's office that is a partnership with the police. And so I think, perhaps there is a bit more of a partnership, and we definitely work with the police at a higher level. We rely on them for data so we know where to target. We rely on them for referrals of people we need to be working with. So on a higher level, there definitely needs to be this cooperation because the police are the only ones that have the data right now. And if we don't have a relationship, we can't figure out what we need to do. But there still needs to be that separation. If you're going to be working with the fact of the matter is, rightly or wrongly, the highest risk population don't trust the police. And there's a lot of very legitimate reasons for that. And so if they don't trust the police and you're working with them, you're not going to have access to them. So you need that separation.
And then my second question, and anyone who is on the first panel, please chime in as well. We've heard again and again in this conference that New Jersey has some of the toughest gun laws in the country, and we do. But if you look at the amount, and I'm specifically speaking of urban violence, gang-on-gang, traditional violence, in our major cities in New Jersey, it has exploded over the last 2 years. So having these really strict gun laws, but yet seeing, and being a very law and order state, we're a very law and order state, but still seeing this incredible explosion in gun violence in urban areas. Why? Well, anyone in the audience would like to also, because I continue to work on initiatives, and, you know, it's difficult for a variety of reasons, but I was wondering other experts' opinions around why we're continuing to see this kind of violence in urban areas in New Jersey.
I guess I'd love to hear if other people have ideas. I don't know the Jersey data well enough, and certainly not the Camden data. There are so many factors that go into promoting the promotion of violence and violence existing in our communities. As a pediatrician, I probably would be kicked out and lose my license if I didn't mention the concept of toxic stress and the stress of our patients and families and communities that create in a situation where violence is inevitable in their lives. And so reducing and ameliorating the effects of stress on individuals and communities is probably that kind of long-term intervention that we have trouble funding, right? Because we have fundus interruptus a lot, and we can't see the 10-year, 15-year goal. So in the environment where there is so much stress in the community and there's so much adverse childhood experiences that create health problems and violence in later life, I'm not sure that any one policy is going to change that. And in Camden, especially from what I understand, and I'm certainly reading a lot about it, there's been an increase in, and tell me if I'm wrong, in a lot of the adverse experiences that people have had, including poverty and food insecurity and racism and all of the things that we understand to affect how people behave in those conditions. So I don't necessarily think a gun policy will change that.
Kathy?
I think all those things are important, and I know in New Jersey we had a pretty marked increase in firearm homicides, right around 2003, 4, 5, and I think part of it has to do with sort of changes in, business conditions, as it were, and sort of the illicit economy, where all of a sudden, for various reasons, it becomes more important for people to be armed, whether there's a shortage of something or competition or whatever, and then I think that sort of diffuses to the whole community for a while. And then after a while, we've seen it sort of come and go a few different times over the last 20 or 30 years. It becomes just sort of this paradigm of, violent behavior. And then the threshold for using lethal force starts to go down and down and down. And, you see people shooting people over being in line at the movie theater or, just all kinds of things like that. But I sort of think the thing that makes it jump rapidly from period to period, I think really at the base has something to do with the business model of some illegal economy.
Okay, well, we're going to thank our panelists.
Thank you.